So Dr. Apsamov Rheumatoid Arthritis. So just to let you know what I'm doing. Definition, risk factor, etiology, pathophysiology, signs and symptoms, investigation, management, outcome. That's what I kind of hope to explain in this video. I found it a bit challenging, especially with the pathogenesis of it all, but I'll try and do it as simply as possible without actually oversimplifying it too much. So I'll just start off with what I've already got up here, just to speed things up, the boring stuff I guess. Or definition. My definition that I like is it's a chronic systematic inflammatory disease that may affect many tissues but principally attacks synovial joints. So if you remember, inflammatory and synovial joints, it's probably the important thing. Risk factors: women more than men, age, peak onset 40 to 50, family history, and there's a reason for that, probably, and smoking is another risk factor. I guess it's a risk factor for almost everything. Now, etiology, they don't really know. Yeah, simply put, don't really know. Maybe it's microbial, or maybe it's a self-antigen. So, yeah, you find rheumatoid arthritis in all different sections in textbook. One has it under autoimmune diseases, others have it in different spots. So, anyways, let's get on to the etiology a bit more. So, unknown reason causes an antigen presenting cell with HLA-DR4 type of major histocompatibility complex, MHC. If you don't want to know, the histocompatibility complex is the thing that the antigen presenting cell uses to present the antigen to, you know, a T helper cell, for example. And if you have one of the alleles or one of the subtypes called HLA-DR4, and it might be a bit more specific in the literature, then you're going to have a greater risk of developing rheumatoid arthritis. So, onto the pathology, or pathogenesis. I'll do the APC again. So that's the antigen presenting cell, APC. Now, what it does is it presents and activates a TH1, so that's a T helper cell. Yep. Now you notice here that I've drawn. I'll just quickly stop. You notice here I've whatever this thing is, a crazy grenade. It's meant to be a joint, a synovial joint. So we have bone here. That's the joint capsule. This green thing here is the synovial membrane, and then blue there, that's just the articular cartilage, and then the blue in there is your synovial fluid, and here is a tendon attaching to the bone, and there's the muscle of that tendon. Yeah, so that's your normal one. I'm not gonna do anything more to this, but this one here I'm gonna mess up a bit as I go. Well, that's the plan. So back to pathology. Antigen presenting cell activates a T helper cell. Now, normally all this is just out here. This can just be circulation. So that T helper cell, blue, is now in the synovial membrane activated. Yep. Now, this causes through cytokines. I don't think for this part it's probably doesn't matter too much which one specifically. I think all of them, cytokines and direct contact. So cytokines and direct contact has the TH1 cell activates macrophages. I'll draw them in a this can be a macrophage here, or lots of them. Now, they don't. When I say activate, what I mean specifically is that they cause them to migrate from. I'll use a different color. So the macrophage can be white, I guess. So macrophages are in the circulation. So there's one in the just in the capillaries around there, and it causes them to migrate into the joint. So we're just in the synovial fluid. Yep. So now we have macrophages. Yep. Now, this is where it kind of gets a bit complicated. So I'll try and do it. I'll come back to the macrophages in a minute. So Th1 cells, cytokines, direct contact. Yep. They cause macrophages. Now the cytokines also promote angiogenesis. Yep. Which is so that's more blood cells. I'll draw a bit of blood in there. Yep. So that causes angiogenesis. So so increased blood supply and all that into the area. Not unlike a lot of tumours. Now, that angiogenesis also increases and helps more macrophages come in. Now, while we're still talking about cytokines from the Th1 cells, the cytokine IL-6 specifically activates or brings in B cells. Yeah. And that also, you can also get that IL-6 from the macrophages. They also secrete that. Yeah, B cells, and these B cells, you know, differentiate into plasma cells. Now, again, when I said they bring in this B cell, I'll just draw a. I can feel I should have been more organised with this. These B cells also are, you know, just hanging out in the circulation. They also come into the joint. Yep. I'm messing up the wrong one. Alright, this one below here can be our normal joint from now on. So they also come in. So we already have all these cells, and normally there's not very many cells in this area. Yep, plasma cells. These plasma cells, as you might know, they make their antibodies. And this includes rheumatoid factor, I'll just write RF. And this also stimulates macrophages. Yep. Not RF specifically, but some of the antibodies and other things they make. Alright. So I think I'll leave that there now. I'll come back to that. So these are all the things that activate macrophages. Now, while I'm here, I'll also mention that these also stimulate the cytokines. Similarly, macrophages also, cytokines, sorry, the Th cells. Macrophages themselves also will produce cytokines that and things will also help stimulate the coming in of more T helper cells, which then causes more macrophages. Alright, so at this point, macrophages, which are really important, so they're white for now. Lots and lots of them in the synovial membrane. Yep. So on to what they do. Okay. They do a few things. They probably not the most important thing, but one thing they produce is, I'm running out of colours here. They produce matrix metaproteinases. Matrix metalloproteinases. Yep. MMPs. You can kind of, just from the sound of it, it doesn't sound like a very thing to, you know, tie in A's proteins. So, you know, they eat proteins. Matrix. So what these do is they do a bit of damage and do a bit of eating to the articular cartilage. So I'll just draw that in there. Yeah, bit of damage there. I'll just write here. Might draw a box actually. So in this is one of the big things I guess we don't want. So cartilage damage. I'll rewrite that. Cartilage. Whatever. So they cause cartilage damage. Yep. All right. So that's one thing the macrophages do. They also produce lots of cytokines, IL-1, TNF-alpha, and IL-6. Sorry, I'm not liking this colour that much. Interleukin 6, and I'm going to write IL-17. No, I won't do that now. Yep. So these together, I wouldn't worry too much about what specifically, but these stuff up. Somehow this leads to. I'm going to write here erosion of bone. So somehow they cause erosion of bone now. Alright, quick hang with me here. So normally they cause erosion of bone. How does that happen? Well, let's review some of the things to do with bones. You need well, actually let's work backwards from that. Erosion from bone. How does that happen? What erodes bone? Osteoclasts. Yep. That's interesting. Where do osteoclasts come from? They come from pre-osteoclast. Okay. That's the wrong area. So they come from pre-osteoclast. Now, how does a pre-osteoclast become an osteoclast? For that to happen, that involves osteoblasts. Osteoblasts. Yep. And how does now? Alright, so osteoblasts, pre-osteoclasts, yep. And pre-osteoclasts have something called rank. Which I'll just draw as a triangle, yep. And osteoblasts produce something called rank L, or rank ligand, rank L, which I'll draw as a, yep. Now, the binding of rank L to rank it causes the transition, or causes pre-osteoclasts to become osteoclasts, right? So they're kind of pretty simple bone metabolism stuff. Normally, you don't have too many osteoclasts and you have a good amount. Now, normally in the synovial tissue, there's not very much rank L, and there's also lots of something called OPG. OPG. Yep. Now, what OPG does is it gets in and it binds with rank L. So that's rank L there, and it binds with rank L and prevents the binding of rank L with rank, which then presents. So what happens is these cytokines, it doesn't matter too much on how they do it, but what they do is they get rid of the OPG, so decrease OPG, and they upregulate and cause way more rank L. So low OPG or no OPG, lots of rank L, then causes lots of pre-osteoclast to become osteoclast, and that causes erosion of bone. Yep. Now that's very. So far we've got erosion of bone and cartilage damage. Now you notice. So what does this erosion of bone do? Now, in the context of all this inflammation going on, I might draw in some bone erosion. So we got erosion of bone. Now, you can see here that I'm kind of having trouble in eroding the bone. I'm also kind of drawing over this synovium, aren't I? And so what happens is that in the context of all this inflammation and this erosion of the bone, it also affects the synovium. Now what it causes is it becomes inflamed plus thick. So this normal synovium that's pretty thin becomes inflamed and thick, and it becomes what they call a pannus. I'm going to draw another box with this, I think. So, different colour. So that's the synovium. So pannus. So this is another, buzzword. So let's turn this normal synovium membrane into pannus. Into a pannus, I guess. Yep. So it was nice normal. It becomes this thick, inflamed, all the cytokines and all this horrible stuff that's going on in pannus. And what it does is the pannus would cause cartilage damage. You can see here. It's not. There you go. Pannus. That's a very. So that causes you cartilage damage. Yep. And there's all this bone damage as well going on at the same time. Yep. Cartilage damage. So what haven't I talked about? Alright, well, while we're actually talking about cartilage damage, I'll talk about another way it occurs. So the antibodies from the plasma cells, they also activate the complement cascade. Yep, causes inflammation. And that also causes your cartilage damage there. Alright, so what next to talk about? One of the things I haven't really mentioned at the moment is one of the early signs of rheumatoid arthritis, which is joint swelling. So I'll quickly talk about that. So I'll just draw another box here. Joint swelling. Why does that occur? You got your inflammation from all your cytokines. There's inflammation everywhere. Half the stuff I've written here is to do with inflammation. You also have your pannus. Just draw this over there. There you go. So if we see this joint that I've gone there, I might just draw it out. It's more going to be out here now. And it's filled with all this. What's a good colour? I'll just do red, I think. So it's filled with this pannus and all the pannus and all these new cells in. You're gonna cause real major joint swelling. Yep. All right. So that's most now. what else have I not thought about? Yeah, hallmarks of rheumatoid arthritis. So, your deformities like people's get Z thumb and other contractions. Um, so why does that happen? I haven't really gone into that. Now, what occurs with these deformities is that you have tightening or I'll just write tendon tendon tightening. You could say tethering, whatever. Tendon tightening, damage, whatever. So, erosion of bone can cause. So, if you think that the bones, here we go. So here's our bone erosion because of all these osteoclast activity. Oh, it's eroding on where the tendon connects to the bone. That's not good. There we go. So erosion of bone is not also will of course affect the things that attach to the bone. So that causes tendon inflammation, slash damage. Now this can tendon inflammation slash damage can cause detachment, which is going to lead to total loss of function. Or it's going to cause to pull away from the joints. And then also, if you look here, from just the simple joint swelling, that's also going to put pressure and pull the tendons away. So I'm just going to write. So you can imagine that if this tendon here gets all this pressure from here, as well as all the inflammation, even all these issues, it's going to cause it to pull, and that's when you get your deformities and that kind of stuff. So I think that's about it for the pathogenesis or pathology of it all. I think for rheumatoid arthritis it's important or useful to think of it in stages. So this is good because this will help us, this will review the pathology as well. So first stage, APC presenting to T cell stage. Yep, you remember that. So what symptoms, signs and investigation you're going to get? Well, it's all going to be negative. Yeah, this is kind of just the start of it all. There's no inflammation or anything yet, but it's coming soon. So stage 2 is, you're going to have, this is when you've actually had some T cell proliferation and also B cells and angiogenesis. But at this point, it's still early on, you don't really have that many macrophages. So what symptoms are you going to get? You're going to have malaise, I guess, from all the inflammation. There is angiogenesis and your B cells and your T cells, so there's going to be swelling, and because of this swelling, you're going to notice people tend to notice a bit of joint stiffness. So it could be anything at this point. In terms of signs, so what you might see on exam is much the same, just swelling of the joints. They might be a bit warm. I'll just write swelling, pain, but just pretty low pain, fairly low, low swellings. Now on an X-ray, it's going to be pretty normal still. So the next point, so I'll do stage 3 now. Now this is when you actually have your macrophages have accumulated. Now, I think the macrophage is probably one of the more important parts of the whole thing. That's, you know, when it gets really serious. So, as I mentioned, you know, lots of cytokines, lots of macrophages. This is when you're going to get your people will notice more joint pain. You know, I actually don't know why it's morning stiffness, because it's not being used. I'm not sure. This is when you get your morning stiffness. They'll notice swelling, malaise, I guess, and maybe some weakness of the jaw. So, you know, you're actually starting to get a bit of functional loss here. Now, findings, you know, you got all this information. So the joints are going to be warm. You know, inflammation, warm, swollen, red, maybe, painful. Now, because at this point it's gotten a bit worse, on investigations, so yeah, some of the inflammation might already be affecting the tendons a little bit, maybe, but so you're going to get a decrease in your range of motion at this point. And on investigation, you might, on say X-ray, this is when you might see some soft tissue swelling. But that's about it, really. Not much else than that. While I'm back, there's RF factor. Now, normally in the first year, that's absent. But you can see here, if we look at the B cells coming early on, once you get your B cells, it takes some time to make it, but that's when you're going to start getting your rheumatoid factor. Alright, so the next stage is probably called penis invasion stage. Penis invasion slash, because these two things can't happen at the same time. Bone erosion. Alright, so symptoms are going to be much the same. Maybe worse probably, but much the same, because, you know, most of these symptoms here are all about the inflammation, and that's already occurred. So the early penis invasion and bone erosion isn't going to change the symptoms and signs all that much. Yeah, they already have painful, swollen, hot joints, and they've already experienced some decreased range of motion. On X-ray, however, this is when you might see peri-articular osteopenia on X-ray. Now, this is when, so, I'm very, very, very far off being a radiologist, to the point that I'll never be a radiologist. But if you look closely, you can see that around the joints, the bones are not as dense; they look washed out, and that's because of the reduced bone density from all the osteoclast activity. And on MRI, this is when you might be able to, you can see some penis, and I don't have an example here. So some of the symptoms now. So 5 stages. So the 5th stage is I don't know what I'll call this. This is probably when you get your cartilage plus ligament problems. So, as I said before, the bone erosion and the penis cause your ligaments inflammation, stretching, penis invasion destroys a lot of cartilage. So for symptoms, you know, still the inflammation. So same, just put arrow, plus loss of function. Now, as you remember, all your joints are, not your joints, your ligaments are all probably tight, possibly. Yep. And this is when you also get your deformity. Sorry, I should be doing this in a different color. Deformities. So this is when, if the ligaments are detached or even just tightened because of the actual physical pressure of the joint capsule, as well as from being inflamed themselves, that's when you get the pull. So again, this picture is terrible. There's loads online, but you can see that you can't even. Here on the MRI, you can see the thumb here. So the ligament will attach there, and then because of all the the ligament attached here, because of the inflammation, the bone erosion causes the ligaments to stretch, so that will pull the foam in, and that's when you get Z-thumb, for example. Yep. So that's for other thing. So signs. So when you feel the joints, there won't be decreased stability, less stable. You're going to get all your flexion contractures. This is when you also get your extra articular disease. I just want to mention, I didn't mention it in the pathology, but just remember, you got all this inflammation starting in the joints. It affects other areas of your body, and you get nodules and all sorts of things. But I don't want to go into that. I think it's beyond the scope of this. More interested in the musculoskeletal problems. Can't see here. So you see erosions of the joint space narrowing. You can see there's not much space there on X-ray. So obviously at this point you know that they have something seriously wrong with them. So this is a bit rushed. I spent all my time on pathology. This has been really long, so I'm going to kind of cut management and outcomes short, but we'll go into what management there is. Probably the thing to know about the most are the DMARDs. So that's the disease modifying anti-rheumatic drugs. So how they work, common things is they block or stuff up TNF alpha. So if we go into the pathology again, so they might work there, TNF alpha. Others work on interleukin 1. Others look at reducing T lymphocytes. And there's a few that do other things as well. Things are corticosteroids. It can be oral or injections into the joint space, and NSAIDs. These both have bad side effects, and they don't really change the course of the disease, and so they're more for symptom management and just your normal analgesics, so like paracetamol is probably a good one because of the chronicity of it. Outcomes, it varies, but usually progressive for life. And it can also reduce your lifespan by 5 to 10 years. That's me done. I'd like to. I didn't have much time to prepare this video, but did it anyways. don't know if anyone will actually find it useful, but thank you